Hello everyone, and welcome. It's really my pleasure to welcome you all to this ESOC 2025 highlight. This is a joint roundtable from American Heart, American Stroke Association, European Stroke Organization, and the World Stroke Organization. We had a very successful European Stroke Organization conference in May in Helsinki, Finland. There were a lot of very interesting presentations and groundbreaking science presenting there. And now today with this webinar, we are presenting some highlights from this conference. And we hope to see many of you in presence next year attending next ESOC 2026 that will be in Maastricht. I am Simona Sacco, President of the European Stroke Organization and Professor of Neurology at the University of L'Aquila in Italy. And I am one of the moderators of this webinar together with Marianne Klinke.
Hi everyone, my name is Marianne Klinke, and I'm here with the American Heart and Stroke Association, and I'm a professor in nursing and a clinical nurse specialist from Landspítali University Hospital and from the University of Iceland, and I specialize in neurology and stroke. So welcome everyone and thank you for joining us. And here today there will be an excellent panel of experts from the three involved stroke organizations. So this webinar is hosted by the American Heart and Stroke Association. However, please note that the recommendations and opinions presented may not represent the official position of the American Heart and Stroke Association. The materials are for educational purposes only, and they do not constitute an endorsement or instruction by the AHA or ASA. The American Heart and Stroke Association does not endorse any product or device. So after the presentations, we'll have panel discussions and Q&A sessions to answer all your questions. So please, everyone, type in your questions in the Q&A section of the site. You will see that in the lower part of your screen, and we'll try to answer them later on during this webinar as our time permits. So currently starting the webinar is Dr. Victor Eurecia.
So I'm Elsa Sanset. I'm a stroke neurologist based in Oslo, Norway. I'm the chair of stroke and general neurology at Oslo University Hospital. It is my pleasure today to present one of the highlights of the ESOC trial, the Bridge-TNK trial. So the background of this trial was that we do have 6 randomized controlled trials comparing EVT alone, TPA and the EVT. When putting all these trials together in an individual patient data meta-analysis, there was no difference between the groups when it came to outcome, having a bridging. However, the majority of these trials used alpha place and not connected place. 2.2% of the participants received pre-treatment with connected place. So still unknown whether connected place prior to EVT is better than EVT alone. So the fact that the Bridge-TNK connected place plus thrombectomy versus thrombectomy alone. 278 patients in the connected place plus thrombectomy group, and 272 patients in the thrombectomy alone group. This was within 4.5 hours
there was a beneficial effect of tenecteplase plus thrombectomy compared with thrombectomy alone within the first 4.5 hours after symptom onset. When looking at, there was more successful reperfusion before thrombectomy with tenecteplase. Tenecteplase group had a 9-minute reduction in the time from puncture to reperfusion. There was less utility of angioplasty or stenting in the procedure, and a higher proportion, as I said, of successful reperfusion before thrombectomy and other secondary outcomes. So these are unadjusted analyses. So these are the key results of the Bridge-TNK trial, and I think we will move on to the next trial and have some discussion on this interesting trial after.
My name is Victor Urrutia, and I am a vascular neurologist, professor of neurology at Johns Hopkins University School of Medicine, and director of the Comprehensive Stroke Center at Johns Hopkins Hospital, and director of the Sheikh Khalifa Stroke Institute. I'm going to present the Optimistmain results. This was a trial that was conducted in 114 hospitals in 8 countries. You can access the paper in the Lancet using the QR code in this slide. These are our funding disclosures. And we sought to evaluate the following issues: whether the high-intensity monitoring for patients with ischemic stroke after intravenous thrombolysis that is recommended by the guidelines and by regulatory agencies, and based on the NINS trial in the 1990s, is necessary for patients with mild to moderate stroke. Also, the other issue is that this high-intensity monitoring protocol incurs in significant nursing resources and costs, especially ICU care, and may be disruptive to the sleep of patients. The concerns are that symptomatic intracerebral hemorrhage needs to be detected quickly, and studies have shown that the highest risk for it is within the first few hours after intravenous thrombolysis. Also, infarct progression and cerebral edema and early complications are a concern. The low-intensity protocol was developed and tested in the Optimist pilot study, in which we kept the every 15 minutes vital signs and neurochecks for the first 2 hours, followed by every 2 hours for the next 8 hours, and then every 4 hours to complete 24 hours. This study had 35 patients and showed no untoward events. The Optimistmain trial was a pragmatic international multi-center step wedge cluster non-randomized non-inferiority randomized trial with intention to treat analysis and evaluating patients that were adults with acute ischemic stroke, post-intravenous thrombolysis, NIH stroke scale less than 10, without any need for critical care interventions or monitoring. And the primary outcome was the non-inferiority based on a margin of 1.15 on the modified ranking score 2 to 6 at 90 days. We also conducted a process evaluation, and at the end, 114 hospitals participated. We screened 9,092 patients and included 4,922 patients. We had to recalculate the power, and which led to 80% power based on our numbers. This is the algorithm that we use for enrollment. The provider team would evaluate patients with ischemic stroke after IV thrombolysis in the first 2 hours to assess for an NIH stroke scale less than 10 and medical stability. If they met those 2 criteria, then they would go on to the standard monitoring protocol or the low-intensity monitoring protocol, depending on whether the site was doing one or the other. This is a summary of what our definition of medical stability entailed, which is basically the lack of need for critical care interventions and critical care monitoring. We saw good adherence to the assigned protocol at both groups and lower utilization of the ICU in the low-intensity monitoring group. And in the modified ranking scale distributions, we saw no significant differences. And the common odds ratio was 1.03, although this was not our primary outcome. In the assessment of the non-inferiority, our study touched the non-inferiority margin of 1.15, and this remained in all the sensitivity analysis. However, no significant differences in secondary outcome or safety were found in the study. Optimistmain low-intensity monitoring, while not conclusively non-inferior to standard monitoring, provided robust evidence of non-significant difference in functional outcomes or complications in patients with mild to moderate severity acute ischemic stroke and are stable after IV thrombolysis. These patients comprise at least 30% of those receiving IV thrombolysis worldwide. Low-intensity monitoring is safe, well accepted by patients, nurses, and clinicians, and likely to produce cost savings driven by lower ICU bed use. Hospitals should consider incorporating this approach to enhance systems of care according to local circumstances and resources. Thank you.
Thank you, Vitor. Welcome, everyone. It's a pleasure to be here. I'm Sheila Martins, past president of the World Stroke Organization. I am stroke neurologist professor of Universidade Federal do Rio Grande do Sul, and I'm the current president of Brazilian Stroke Network. And it's my pleasure now to talk about two very important trials presented during ESOC. The first one, secondary prevention, phone-based intervention under nurse guidance 2, the PINKS2 trial. So, heavy and rising burden of stroke in Africa with population attributable risk of hypertension for stroke occurrence is 91%. Long-term blood pressure control in Africa is constrained by overburdened health physicians, health systems, paucity of doctors, lack of affordable drugs, and patient-level factors. But we have a huge opportunity using digital health tech plus task shifting with nurses. This could be a viable strategy for addressing poor blood pressure control after stroke in the region. So the objective of the study was to demonstrate efficacy and safety of mHealth technology-centered, nurse-led, multi-level integrated approach to substantially improve long-term blood pressure control among recent stroke survivors, so secondary prevention of stroke. The candidates were stroke survivors more than 18 years old with uncontrolled blood pressure, systolic blood pressure more than 140, within 1 month of symptom onset from 5 primary level, 2 district level, and 3 tertiary hospitals in Ghana. Participants were enrolled from October 2020 to April 2023, and the last participant completed follow-up into April 2024. They were randomized to use PINKS intervention against usual care. So PINKS intervention comprised domiciliary blood pressure, self-monitoring with digital equipments donated by the study, weekly nurse case management for blood pressure, phone alarms as medical reminders, and once week education about cardiovascular risk reduction via regular telephonic audio messages. The primary outcome was decrease the blood pressure less than 140 at 12 months in relation to principle, and secondary outcomes measure adverse cardiovascular events. So let's see. Here you can see they randomized 500 patients, half for usual care, half for PINKS study, and at the end they analyzed 410 patients. So 43% of participants were women, 82 participants complete the trial and had the final analysis. And the primary outcome, so important, you can see in your right in the bars, diastolic blood pressure and systolic blood pressure during the months. And you can see intervention group in red and in gray, the routine treatment. With the time, they increase the difference, better control for the interventional group. So the primary outcome shows 67% of patients with PINGs versus 43% with usual care, well-controlled blood pressure, systolic less than 140, with between group difference 42% with statistical significance. So this is a very important achievement. Stroke patients who receive usual care were 36% less likely to achieve systolic blood pressure control during this 1 year. So for the major cardiovascular events, we have numerically more events, 6.36% with PINGs and 4.7% of usual care. But of course, this is a small sample size to achieve this. The main outcome was the reduction in control of blood pressure. So in conclusion, in patients in Ghana with recent stroke compared with standard care, AMI Health technology centered nurse-led integrated approach was associated with better blood pressure control at 12 months after stroke. This is the first large multi-center study to evaluate the effectiveness of nurse navigate AMI Health in intervention in blood pressure in Africa. There is studies in US and UK using smartphones, Bluetooth technology, and more sophisticated technology. But the intervention now can be scalable through Ghana, and I'm sure, of course, other sub-Saharan African countries. And the cost to implement this program was $540 over 12 months to implement the intervention, compared with $1,500 per participant when you use more sophisticated study protocols. So I think very important study for low and middle income countries using task shifting and technology to improve the blood pressure control. Congratulations for the authors, and thank you to Bruce Abigail that shared these slides. So the other very important trial is advanced stroke safety and efficacy through early tirofiban administration after intravenous thrombolysis, the ASCETD randomized clinical trial. Thank you to Dr. Wei Hu that shared these slides too for this acute care phase clinical trial in patients candidate to IV thrombolysis that is a standard of care up to 4.5 hours of symptoms onset, but reocclusion risk remains, especially in patients not eligible for thrombectomy. Previous trials tried to use antiplatelet to reduce the reocclusion, but they fail with more risk of bleeding, mainly with aspirin and eptifibatide. So the hypothesis of this trial is to use early tirofiban, acting IV antiplatelet, that may improve outcomes without an acceptable bleeding risk. So 832 patients from 38 centers in China were randomized to receive tirofiban versus placebo in patients receiving IV thrombolysis up to 4.5 hours of symptoms onset. Thrombolysis could be alteplase or tenecteplase. 75% receive alteplase in this study. Timing, tirofiban or placebo should be infused for 24 hours and started within 60 minutes after thrombolysis. The mean start of tirofiban was 44 minutes from the start of the thrombolysis. Primary outcome, modified ranking scale 0 to 1 at 90 days, and safety outcomes, symptomatic intracranial hemorrhage within 36 hours, and mortality in 90 days. So the results 66% of patients receiving tirofiban and 55% receiving placebo had a modified ranking 0 to 1, minimal or no disability, so better for the intervention for tirofiban group. The risk ratio 1.2, you can see here, was significant with very low rate of hemorrhagic transformation, symptomatic hemorrhagic transformation, 1.7 in tirofiban group versus 0% in the placebo group. The mortality was similar between groups, was 4%, very small mortality. And the conclusion in this population, tirofiban improved excellent outcome at 9 days with low symptomatic intracranial hemorrhage risk. Remember, in the selection of patients, they exclude patients with atrial fibrillation. And remember that is important, these patients, if you see, they have a lot of large artery occlusion, mainly intracranial large artery occlusion, but I think it's a very important trial and would be wonderful to replicate this in the Western population, because I think we can improve the outcomes with thrombolyzed patients. So now it's my pleasure to introduce Professor Craig Anderson. Craig.
Oh, hello, everybody. It's a great pleasure to be part of the panel and to give an overview of another trial. I'm President-elect of the World Stroke Organisation, a stroke neurologist working at the George Institute in Sydney, Australia. I'd like to present the results of the Chinese Erase Stroke trial, and I need to confess that I'm a consultant to the company that sponsored this trial. That may be a conflict of interest, but it may also mean that I know a little bit more about the agent and the trial than other people. And this is a controversial area around neuroprotection that you all know. We've spent 40 years evaluating neuroprotection in acute stroke with not much success, but this was a positive trial with the drug Adaravine. It has a special name from this company as an oral agent. There are some intravenous agents available. This was a multi-center trial, double-blind, placebo-controlled, patients with anterior circulation acute ischemic stroke who weren't eligible or were outside the time window for reperfusion therapy within 24 hours of onset. And Adaravine is approved for ALS, motor neuron disease, and for acute ischemic stroke in Japan and China. It's quite novel. It's an antioxidant, free radical scavenger. It's a small molecule, easily crosses the blood-brain barrier, and the oral formulation has a very high bioavailability, actually quite equivalent to an intravenous dose. And the purpose of the trial was to give treatment over 28 days. There'd been some preliminary data to suggest that the longer period was better than a short period. And this positive trial, and I'll show you the data in a minute, follows on from two other positive trials by two other groups. So there's 3 independently conducted clinical trials in China that have all shown a positive result with the agent. And this is the Grotta bars showing the significant difference in the distribution for the Adaravine group. And most of that improvement was in the minor grades of disability, very low mortality and severe disability in this group, and that was highly significant for improvement. These are all of the secondary outcomes. And I thought it's quite interesting because with reperfusion treatment, you can see an effect within 24 hours. You'll see an improvement in the innate stroke scale. But with neuroprotection, it's more of a long-term improvement. So although these were not significant, you'll see on the measures that they all improve progressively over the 90-day period. So it's a different way of evaluating the success of neuroprotection as opposed to our understanding of reperfusion. So these are very interesting results, although arguably a little bit controversial. The 3 positive trials are all Chinese. There clearly needs to be an international clinical trial, and I'm pleased to say that the company are planning that to seek broader FDA approval. In this context, we know that the most recent trials with NA1 in the ESCAPE program were not successful, but if this is truly a positive result, then this could be potentially a major game changer in stroke care, which we've all been trying to establish over many decades now. So thank you very much. I'll pass it back to the panelists.
Thank you, Craig. Thanks a lot for this excellent presentation, and thanks to all the speakers for the very nice and clear talks. And now we can open the floor for the discussion, and please go to the Q&A function and add your question there. And we can start the discussion with Craig, probably discussing this trial, but also we have the results of the tirofiban trial presented by Sheila. As Craig mentioned, both of them were performed in China, so in a population with a different ethnicity, different system of care. And so my question is for both of you, how those results can be translated to other settings and different populations. How do you think that ethnicity and different settings really impact on those results?
Look, I'm happy to go first, Sheila. Look, it is a controversial topic. I know ESO has experienced this controversial topic in the past about ethnicity and stroke outcomes. I'll give a kind title for that. Look, there is no doubt that cerebrovascular disease pattern profile is different in Asia, China than in the West, Caucasian. There's more small vessel disease. There's more intracerebral hemorrhage. There's more intracranial atheromatous disease. And there are differences in the background care. There's more traditional Chinese medicine in China. There's more natural therapy in India. Hypothermia is used more routinely than elsewhere. But in a randomized controlled trial, background care should be equalized, should be balanced. And so the evaluation of a treatment is on background care. And in these trials, it's double-blind placebo-controlled, which even means that you're not introducing clinician bias in differential therapy or evaluation. So these are the most rigorous. And the other thing is that you have 3 independent groups doing their trials with different networks, all having a consistent positive result. So there does seem to be a plausible signal here, which could be, applied more generally in the world. Obviously, we always feel comfortable having direct randomized evidence in our own population. And as you know, the US FDA clearly wants treatments to be evaluated in the context of their healthcare, which, as I said, the company are prepared to fund and undertake to do that.
Sheila, anything to add from your perspective?
Yeah, well, Craig knows everything about China. He has a lot of experience, but I think a large clinical trial in the Western population is important because of the ethnicity and the difference in the case of the tridophan, mainly because of a lot of atherosclerosis, intracranial atherosclerosis that can benefit the treatment. But I'm very excited with these studies, both of them. Craig showed the first positive neuroprotection trial. I think we should follow these results for a large one, and tirofiban I think can be used in our routine. So I think we need to wait on new trials.
Craig, I was wondering, you mentioned that the results may be a little bit controversial that you presented. What concerns have been raised, and how should a follow-up international RCT address these potential biases that you have seen within this response? Also, if we think about placebo response or regional variability in standards of care.
Yeah, so I guess the controversy is that it's predominantly Chinese, and despite the massive increase in randomized controlled trials coming out of China and the quality of the science, there's, and be honest here, there's still a little bit of suspicion or, worry. And so it is important to try to do the trial outside of China to look at the consistency of the result, and we see various examples of that around the world. The other thing is that it was patients who didn't receive thrombolysis. I think in the West, a high proportion now, we're probably achieving about a fifth of our patients getting thrombolysis. So it is a non-thrombolysis or non-reperfusion group that still would benefit. And the other issue is it's an oral agent, and I guess that may worry some people about should we need to get the treatment in early. But maybe this type of neuroprotection doesn't work through the mechanisms as an adjuvant to reperfusion, like potentially theoretically other ones. It may work when there is a ischemic injury. It may work on the repair processes that occur. So maybe timing may be less relevant. So we were thinking about, that most people who have dysphagia would probably get an NG tube in the second day for their antihypertensive medication, anticoagulation medication, nutrition, those sort of things. So I don't think that the use of an oral agent is a great limitation, but it may cause some apprehension to some stroke neurologists, again, in terms of the generalizability of the management. So it's a positive trial, but there's still some aspects of it that make us a little uncomfortable about how the results fit into our patients and our clinical practice in the West.
Thank you.
Thank you, Craig. A lot of questions are coming, so really we will try to address most of them. And I can see that there's a lot of interest in tirofiban, Sheila. There are questions coming, and probably we need to clarify if at this stage this drug is suggested by guideline, and there are some of those who are following this webinar that ask if tirofiban is more effective than aspirin after 24 hours from stroke onset, and if there's any evidence for use in patients who did not receive thrombolysis and thrombectomy.
There is trial comparing the use of aspirin and tirofiban patients without thrombolysis and showing the better effect for tirofiban using the first 24 hours of symptoms onset. As I know, in the long term, I don't know. I think there is no trial to show this. So the other question is about patients with, so this trend trial was comparing aspirin and tirofiban, showing that the better outcome for patients with tirofiban. This excluded patients with thrombectomy, but we know that there is neurointerventionalists use tirofiban in patients that, for example, receive thrombolysis and need a stent, intracranial stent or carotid stent, and need antiplatelet. They prefer to use tirofiban too, but it's not a clinical trial. So for this one, this trial, I think we will not change now our guidelines for patients with thrombolysis, but there is a possibility, and I think we need a clinical trial in other population to confirm the results. And there is another question I saw about eptifibatide. There is another trial using eptifibatide in patients with thrombolysis, because we are trying to decrease the reocclusion, and the trial with eptifibatide was negative, didn't show difference using eptifibatide or not. So for now, tirofiban looks like the best drug for this to use together.
Thank you, Sheila. Thanks for clarifying those very important points.
I was wondering, Victor, I really want to talk a little bit with you about the Optimist trial, because it has really great implications also for nursing surveillance. And when reading the trial, it seems like the low intensity monitoring was delivered under fairly good conditions, for instance, with staff that were fairly competent to stroke monitoring after TPA. So how transferable are these results to less resourced settings? For instance, in high functioning stroke units, nurses are used to detect subtle changes, but in settings with limited stroke expertise, or where they have weaker support systems, or where they are basically maybe implementing new stroke units, they may not have the same clinical eye. And I was wondering, if we diminish this surveillance, could it have any impact on the safety? And I would really love to hear your thoughts about that.
Yeah, thank you for the question, Marianne. I think that the best thing about the Optimistmain trial is that it was a global trial, so it was implemented in places with different resources. If you think about it, 4 of the countries that implemented the trial are considered low and middle income countries. So there was a variety of expertise and resources within the trial. So I would say that the generosity is actually quite good. There's definitely, for any stroke center, a minimum of training that is required for nursing, and that is something that it's really helped by the process of certification, and it's good to see that certification is really going all over the world through the WSO and AHA and ESO. So I think that, again, the fact that we had 4 countries in the low and middle income country level show that these results are applicable in a variety of environments.
Thank you. I was also thinking about the amount of patients actually that were excluded from the trial, because it was actually approximately half of the patients, wasn't it? And what if we have patients who are excluded with under NIH 10, and we have this because they are critical patients in some way, But how do we define this, like medical unstable patients, a little bit better or clearer? And what is the way forward with that to define that group a little bit better?
Right. So that's a great question. The difference between the enrolled patients and the screened patients is not surprising. As I mentioned at the end, the population that we were targeting represents about 30% of all IV thrombolysis. So we actually enroll a little more than 30% of the patients that we screen. So I think that that's a pretty good number. Now, the medical stability was defined as I mentioned, in quick terms, no critical care intervention requirement or no critical care monitoring requirement. Now, to make that a little more specific, we required that no invasive or non-invasive ventilation was needed for the patient, that no drips, either to increase or decrease blood pressure or any other cardiac medications, that no a high risk of deterioration due to worsening of edema or worsening of the stroke was expected. And at the end, we left it at the treating physician to exclude anybody that they felt might require the critical care monitoring. So the criteria are broad and pragmatic. And again, if you think that the patient doesn't need ICU care and is medically stable in that sense, and they had an NIH stroke scale less than 10, that's the population that we enrolled.
Thank you.
Thank you,
Craig,
Victor.
I don't know if Craig wants to add something. He's co-PI of this trial.
Oh, thanks, Victor. Yeah, look, I think we've got to thank our nurses tremendously, because in 30 years since approval for thrombolysis, the nursing role in the stroke unit has increased remarkably, and it's very busy. It's very demanding. When you had thrombolysis 30 years ago, it was monitoring. But now we have care, protocols, accountability, certification, groin management, discharge planning. It's busy. It's busy. So we've shown that a low-intensity monitoring is safe. It can free up the nursing resources in more active ways rather than just recording monitoring, which they get very frustrated by. And they feel more engaged with the patient rather than waking them up through the night to disrupt them to do a monitoring test. So as Victor emphasised, and the beauty of these international studies is the generalisability, but a big trial gives you an average effect. And as you know, individual patients in individual hospitals, the size of the effect will vary a little bit according to the context. So in situations where nursing resources are high cost and ICU care is a high cost, then the benefits of our intervention are going to be much greater. In resources where there are lots of nurses at low cost, maybe it's less effective, but the problem in those contexts, which is generally in low resource environments, they don't have the same level of skill as you would expect in a high income country. So downgrading or shifting the resources in those contexts may compromise the level of care because they don't have the same standard of care. So you have to understand the context in which you are applying, changing the levels of care. But overall, very safe. The risk of intracerebral hemorrhage in this patient group is tiny, 2 in 1,000. We should relax worrying about intracerebral hemorrhage.
What would we need to bring it into clinical guidelines?
Yeah, one question from my side to Craig, Victor. Do you think that the same results can be translated to patients with ICH, same NIH score threshold, same medical stability, or does this deserve a proper randomized control trial?
That's a great question. So we did a study at Hopkins, a retrospective, trying to get some early signals of this, and we found that the approach is applicable, but I do think that we would have to do a randomized trial because intracerebral hemorrhage has different characteristics, and we know that 30% of patients can expand their hemorrhage in the first 24 hours. So the dynamics of the condition are going to be different, and I think that we might need to use other factors, perhaps biomarkers like the spot sign or blood pressure on arrival, and things that may help us determine who can be monitored less intensively, but I think it needs to be tested in a randomized trial. I think that this is specific for the post-IV TPA, post-IV thrombolysis population. And if I may add also about the nursing, it's really important for nurses to be free to do mobility interventions, early recovery interventions, education, psychosocial support of the family and patients. So I think that's really as Craig said, that this is the benefit of this trial.
Thank you, Craig. Do you want to add anything?
I agree with Victor. As clinicians, we worry about harm, we worry about bleeding, we worry about bleeding in the brain. We need to have the direct evidence, but I think we're a bit overly cautious with the stable, small hemorrhages. I've had a patient today, small hemorrhage, up and about walking, no problems. But I think we worry about harm to our patients, so we need to do the randomized evidence to reassure us about that, and that's why we put the effort into Optimist.
Very relevant comment in the chat as well, saying some of these patients are probably better off that we let them sleep and we don't push them into the delirium, which I think is also we do all these observations, and that might also, for some patients, be more harm than good. So
I completely agree with that. And we are evaluating the impact of sleep, and that should be coming up as another publication. So we have some information about that.
Else, there's one question for you. Bridge-TNK is a trial that probably will not change guidelines, but will reinforce what we're doing today, that is bridging over thrombectomy alone. But probably this trial will help to quit some controversies about this approach. So the question is, do you agree with this? And the additional question is that you showed that with bridging therapy, there were some reperfusions, and so there are some thrombectomies that can be avoided. Can you provide the figures on the numbers of thrombectomy that can be saved with the bridging?
I don't have the numbers, but there were 6% of the patients in the tenecteplase thrombectomy group who had successful reperfusion before thrombectomy versus 1% in the thrombectomy alone group, which I haven't recalculated that into patient numbers, but so there are some thrombectomies that could be saved. And I also think this provides even more reassurance that tenecteplase can also be used successfully in this patient group. So I think we need to keep in mind that this was within the 4.5 hours since symptom onset. There was a comment in the chat as well regarding how this compares to the timeless trial. And the timeless trial did not show an effect on functional outcome, but that was, of course, done in the extended time window. I think the mean was 12 hours after symptom onset, so it's not directly comparable, these two trials. So.
Okay, and now we will move on to the Q&A session after concluding this really good panel discussions now. So we will put more emphasis now in looking at the questions that you have sent in, and I would again like to encourage you to submit your questions in the Q&A function here below. So there's one question here to Sheila again, where it says non-adherence to medication is usually a problem for African patients, especially those who might not have the money to consistently pay for medications. Was this a problem in the PINK study, and how was this issue addressed?
Sorry, I didn't understand the initial part of.
I think it's more about the economic status, the cost of the intervention.
Because what they showed was that this cost is lower than the usual cost, and we know that control the blood pressure will decrease the risk of stroke and will decrease the general cost of treatments and the cost for the health insurance and health government, because we decrease the burden of stroke and hospitalization and lack of work. So I understand that a problem they have there, and they talk about this, is that the medication is not free for them, and I think needs to be insured, because one thing is to control the blood pressure, another thing is to have access to free medication. This is the key to really decrease the burden in African and other poor countries. So we cannot solve this, but at least this lower cost can solve the problem to control the blood pressure. And we need to work with the governments, and I did, and Craig will do when he will be the president. We are trying to work to include these medications for hypertension and diabetes affordable or free for the patients, mainly in the low-income countries.
Thank you.
Craig, there are some questions regarding the trial you presented. It's about neuroprotection, and those who are following this webinar are asking why this trial was positive. It's only about the drug that it's effective while other drugs were not effective, or there's something in trial design, population that can explain these positive findings?
I think we've found that every neuroprotective drug is positive in rodents and pigs and monkeys, but it doesn't work in adult human patients. And so people have come up with numerous explanations about that. And here we have a neuroprotective drug that is positive. So, of course, it causes us a lot of surprise and soul searching over the mechanisms, because how many? There's been a systematic review, 100 different neuroprotective drugs which have all shown positivity, different mechanisms, and here we have one that is positive. Well, I mean, we have to accept it's probably strongly related to the agent, is, something about the agent, because the study design, the patient groups have all been pretty consistent across various studies. I know there's very much a focus now to get as early as possible with a neuroprotective drug, to have it within the neuronal tissue, within the cerebral circulation, in the context of reperfusion injury. But those agents have a particular mechanism. I'm not a neuroscientist, so I can't explain that particularly well. But this edaravine, which the FDA have approved for the treatment of motor neuron disease, does have particular unique antioxidant properties. And maybe that's the mechanism that it works. I think there'll always be a bit of mystery about how do things work in the human brain, because we don't have an ability to get a very reliable biomarker. You know, we measure the footprint of the ischemic lesion at 24 hours on an MRI or a CT, but, you know, it's a picture. It's a picture which is not always necessarily, you know, strongly correlated with what's happening in the brain tissue. And we do see remarkable recoveries despite a large ischemic deficit. So I can't give a simple explanation. You know, I've got an open mind. We wouldn't be doing science if we didn't, you know, follow a path which we believe in. There's no point in doing research if we don't think things work. We do research because we believe in them, that they're going to make a difference. We follow a path. This looks a very encouraging signal, with those caveats that I mentioned before, that it is encouraging, but I don't think we would recommend it as a standard of care outside of China, because we're uncertain about how it works in our patients as opposed to the Asian patient.
Okay, and I have one. I think it will be probably the last question here for Sheila. What was the common barriers and difficulties found during the implementation of mHealth technology centered nurse-led multi-level approaches to improve the blood pressure control in Africa? So what were the main barriers to this implementation?
Well, really, I think this is a very good strategy, and globally we are trying to really work more with nurses, and we think we should do this for the blood pressure control. They are perfect to help the patients to control the blood pressure and try to put the blood pressure in the main goals. We have studies from Salim Yusuf with community health workers following algorithms and deciding to give antihypertensive or not. So I think this is the way to control blood pressure globally. So we need to implement.
Yeah, I totally agree. I think it's an awesome approach, actually, that could easily be implemented in many other places as well. So thank you so much, everyone. And we have certainly had a lot of great questions, but unfortunately time runs really fast, and we're out of time now. But before we wrap up, I would like to mention the Global Stroke Action Coalition. So as founding members of the new Global Stroke Action Coalition, the American Stroke Association, the European Stroke Organization, and the World Stroke Organization want to encourage all of you in the audience to help us make stroke a priority among policymakers around the world. So next week marks the 100-day mark until the UN high-level meeting for non-communicable diseases. So we would ask each one of you to actually pick up your phones now and take this QR code and sign this statement here. By signing this letter to support, it helps us to urge world leaders to make stroke global priority. So please share this both with your colleagues and social networks so we can be spreading the word. Thank you for joining our organizations for this webinar today. And we will be sending an email with instructions to fill out a survey. And you will also have an option to claim a certificate of attendance. Thank you for participating.